For lupus is a multi-system disease that can attack any part of the body. Kidneys being part of the body do a lot for the body, can get affected from the activity of lupus disease. And these patients who have diagnosis of SLE are at very high risk of developing kidney disease. And when kidney disease occurs in these patients, it usually occurs within the first 5 years of diagnosis of systemic lupus erythematosus. And it can affect somewhere from 50 to 60% of patients. As you know, lupus can occur in children too. And in children, if lupus involves kidneys, more than 80% of children can have inflammation of the kidneys from lupus erythematosus. And sometimes we see patients where we diagnose lupus because they present to us with some kind of kidney disease. And when we biopsy them, we find out that they have systemic lupus erythematosus. So way before they fulfill the criteria for diagnosis of systemic lupus erythematosus from 4 out of 11 criteria Dr. Schwartzman talked about for diagnosis of systemic lupus erythematosus. And patients with systemic lupus erythematosus, if they happen to have other systemic diseases like diabetes as well as hypertension, can develop kidney disease because of those systemic diseases as well. So how do we define lupus nephritis? As you heard before, lupus nephritis means something abnormal in the kidney, inflammation, and as a result of an inflammation, there is damage in the kidney. Normally, when we all pee from time to time, there are usually no red blood cells which mark the presence of blood in the urine. But in a patient with lupus nephritis, you start seeing presence of blood in the urine. And we find out because when we take the urine specimen from the patient and look it under the microscope, we see red blood cells under the microscope. And along with red blood cells, sometimes these red blood cells, if there are too many of them are being passed together, then they can form a cast inside the tubule of the kidney and can go out and be present in the urine as red blood cell cast. And once we see red blood cell cast, which looks like something like this under the microscope, in a patient who carries the diagnosis of systemic lupus erythematosus, it makes the diagnosis of nephritis in those patients. Normally, we all pee out almost 150 milligram of protein per day in our urines. In a patient with lupus nephritis, usually we pour much more than 150 milligram. Usually, if more than half a gram of protein is being excreted into the urine on daily basis, this makes the diagnosis of lupus nephritis. Blood markers for kidney function like high BUN, blood urea nitrogen, or creatinine, if found, they signify that the kidneys have been affected in a patient with diagnosis of lupus. And it can, as I mentioned, lupus nephritis can occur both in adults and children, but much more commonly in children, where more than 80% of patients can be affected. So when you take urine from patients who suffer from diagnosis of systemic lupus erythematosus, and if you run their urine analysis, the most common abnormality which we find in these patients is the high level of protein in the urine. Almost 100% of patients will have abnormally high level of protein in their urine, which could be more than 150 milligram, could be 500 milligram, could be 1 gram, 2 grams, 3 grams, or 4 grams of protein. And the second commonest finding in these patients is that their kidney function is abnormal. So when you check the blood markers for kidney function, blood urea nitrogen or serum creatinine, those levels are abnormally high in these patients. Other abnormalities which could be seen is microscopic hematuria. As I mentioned, when we spin the urine and look under the microscope, you can see red blood cells under the microscope. So how do we diagnose a patient with lupus suffering from lupus nephritis? Usually patients, when they have inflammation in their kidney from lupus, they don't feel well. They usually have a flare of lupus at the time of involvement of the kidneys. So these patients usually feel fatigued, they have butterfly rash on their face, they have suffered from arthritis, some of them can have brain involvement at the time of kidney involvement, and these patients are sick at the time of diagnosis of lupus nephritis. Some patients can be completely asymptomatic, and you will find out about the kidney involvement when you start looking for it. You send their urine to the lab to check out urine analysis, or you look for protein and you find out that they have abnormal amount of protein or blood in their urine, but they otherwise feel fine. Some of them, if they lose a lot of protein in their urine because of the immune complex deposition, they can retain a lot of water from the kidney and can develop high blood pressure, and few of them actually can develop hypertensive emergency when they come to the hospital with symptoms of very high blood pressure like headaches, not feeling well, dizziness, and few of them can develop actually heart failure because of the so much water being retained from those kidneys. And when as physicians we examine those patients, these patients usually have evidence of active lupus. As you have already seen, that these patients have butterfly rash on their face, they can have ulcers in their mouth, in their nose, they can suffer from joint involvement at the same time, so the joint may be swollen. Sometimes they will tell you that they see their urine being kind of Coca-Cola colored. That means there is blood in their urine. So some of them, not every single of you can probably has seen some evidence of blood in your urine, but those who do will tell you that the color of the urine has changed. And few of them, when they pass a lot of protein in the urine can actually look very frothy. It looks foamy. As you flush the toilet, you could see bubbles at the surface of the water in the toilet. So that signifies that there is a passage of abnormal amount of protein in the urine. Some patients with active lupus, when it's very aggressive in the kidney, because of retention of salt and water, can develop hypertension. And because of the salt and water retention, they can retain extra water in their loose parts of the body. Usually they accumulate water around their eyes, in their legs, in their abdomen, in their other cavities of the body, where it can give rise to other signs and symptoms. And sometimes because of passage of large amount of protein, some patients suffer from what is called as nephrotic syndrome, where the patient becomes very, very swollen from the too much water in the body, and they can have water in their abdomen, water in their lungs and the heart, and can have consequences as a result of that. How do we diagnose? As you learned before, we do blood tests for kidney function. Usually blood urea nitrogen and serum creatinine are taken as the markers of kidney function. So if these are elevated, these two tests in a patient who suffers from systemic lupus erythematosus, you should think about their kidneys being involved from lupus nephritis. And then at the time, as I mentioned before, usually there is an active lupus flare at the time of kidney involvement. So if you run the blood for tests looking for activity of lupus, usually find that their DNA titers are very high, complements level as a result of complements being used by these antibodies levels are low, and at the same time other markers of inflammation like ESR, which is a erythrocyte sedimentation rate, reactive protein level, they are very high at the time of diagnosis of lupus nephritis. Urine tests, we take urine specimen from the patient, we spin it under the microscope. What we look for is the presence of these guys, these little empty looking cells. These are the red blood cells, which normally should not be seen in urine of a person without kidney disease, but they are seen quite often in patients who have nephritis from lupus in their kidneys. And this is the red blood cell cast, which can be seen. And if, as I mentioned before, if this is seen, this is diagnostic of nephritis in patient with lupus. And these two tests are kind of non-specific. So we have to proceed to what is called as kidney biopsy. We had to stick in a needle to take a small piece from the kidney to see what it looks like under the microscope, to assess the severity of lupus in the kidney, to decide for the treatment in future. So this classification of lupus nephritis was put together in 2003. There have been multiple revisions of lupus nephritis classification based on biopsy by WHO since 1972, but this is the latest classification, which is followed up by the nephrologists as well as pathologists throughout the world. So this classification actually divides lupus into 6 different classes, and for your knowledge, class 1 and class 2 are usually the milder form of lupus nephritis in the kid on biopsy. So if somebody biopsy comes back as class 1, minimal change, where you don't see much under the microscope, only immune deposits are seen either by immunofluorescence or by electron microscopy, then it's class 1. Class 2 is little more advanced than class 1, but having class 1 and class 2 is usually good to have, because the treatment of this type of lupus nephritis is what you would need otherwise for treatment of lupus going on in the body. Class 3 is seen somewhere between 10 to 20% of patients. This is a relatively aggressive form of kidney disease in patient with diagnosis of SLE. And class 4, as Dr. Schwartzman mentioned, is the most aggressive form of kidney disease in a patient with diagnosis of SLE. So this is what we worry about, because if it's left untreated or somebody does not respond to treatment, it can lead to rapid onset of end-stage kidney disease, having the patient to start dialysis or undergo transplantation because of this particular kind of class on the biopsy. Class 5 is a disease where you don't see a lot of activity on the biopsy in the kidney, but in this particular condition there are a lot of immune complexes deposited in the basement membrane of the kidney, and as a result of deposition of those immune complexes, kidneys become very leaky and they leak a lot of protein into the urine. And class 6 is when either you gave treatment to the patient and patient did not respond, or patient did not want to be treated. It leads to a lot of scarring because of the inflammation, and more than 90% of the kidney actually shows scarring on the biopsy. Then it's called class 6. That means that there has been irreversible damage to the kidney and patient needs to start dialysis or undergo transplantation. So this is to show you what we look for in a biopsy. It looks a little strange, but this is what is called as nephron. This is the building unit of the kidney. This is the basic cell of the kidney. It has two parts. One is this globular part called glomerulus, and one is the other part is the tubular part called tubule of the kidney. In glomerulonephritis from lupus, glomerulus of the kidney, the globular structure is the most commonly involved area of the nephron which is affected in lupus. So if you see, normally this is how glomerulus look like on kidney biopsy, where the glomerular capillaries basically filter the blood from the blood vessels to make it ultimately the urine which we pass from time to time, and this urine made by these capillaries in these empty spaces filters out in this space called urinary space, and from here the urine goes into the tubules to ultimately be made into urine. In a patient with lupus nephritis, depending on the class, it can look like somewhat like this, that the cells of these glomeruli look a little bit more in number, as well as the matrix looks a little bit more. Other than that, there is no necrosis or death that could be appreciated on the biopsy, so that's good to have. This is what we worry about as nephrologists, that class 3 or class 4 lupus is very, very aggressive lupus, and if you don't treat it in an aggressive manner, patient has the risk of losing the kidneys and proceeding to end-stage renal disease. So on biopsy, you could imagine, as compared to previous normal glomerulus, this glomerulus look very busy. It has these areas which look red, which means there has been a lot of fibrin in this area, which is another marker of cell death and damage in the kidney. And in this glomerulus, what you see is that the cells in the urinary space of the kidney are multiplying too fast because of the inflammation, and as they are multiplying, they are collapsing the capillaries of the kidney and pushing them onto the side. So this is what is called as crescent on a kidney biopsy, and when you see crescent on a kidney biopsy, that means it's a very active lupus, and if treatment is not started soon, patient is going to lose the kidneys permanently. And this is what the class 5 looks like. Again, in this slide, you see that the glomerulus does not look very busy. What you see is these black, thick areas which reflect that there has been immune complexes which have been deposited in this part of the glomeruli. And when you do what is called as electron microscopy, you see these immune complexes on the outer side of the basement membrane, and they make the basement membrane very leaky. Normally, we don't leak a lot of protein through the basement membrane into the urine, but in these patients, sometimes we see 10 grams, 20 grams of protein being lost into the urine. And this is a very rare type of nephritis which is seen in a patient with diagnosis of SLE, but usually at Jacobi we see quite a few patients. On the biopsy of these patients, the glomerulus looks absolutely fine under light microscopy, but when you do electron microscopy, you don't see any deposits in the basement membrane. Immune complexes are not seen, but one of the filtration barrier on this basement membrane is lost. Those are the food processes which prevent the formation of protein and letting them go out into the urine. So once you lose those food processes, those proteins find it very easy to go out into the urinary space and be lost. And it's called lupus podocytopathy. And it's very responsive to treatment. So if somebody's biopsy comes back as lupus podocytopathy, that's something good to have. And this is what we see on the biopsy when we stain it for different antibodies. So this is a special stain called technique called immunofluorescence, where we stain the biopsy. So these immune complexes which are formed in the bloodstream of the patient get deposited in the glomeruli, in the tubules, and in the blood vessels of the kidney. So all areas of the kidney get affected from lupus, and these antibodies are all kinds of antibodies in the body. It's called full house in the kidney. You see all kinds of immunoglobulins into the kidney of patients suffering from lupus nephritis. As you saw before, other than knowing what your class is on the biopsy, it's important to know how active or chronic the disease is on kidney biopsy, because your treatment depends, and response to treatment depends on how active or chronic the disease looks on the biopsy. So knowing activity and chronicity index helps out in treating as well as making a prediction about prognosis.